It's our pleasure to invite the next speaker, Georgios Mavrogenis, already a member of Bucharest Live endoscopy family so far. So the next talk will be about the endoscopic therapy of gastrointestinal subepithelial tumors. Please, Georgios.
Bună ziua! Mulțumesc mult pentru invitație. România este a doua mea casă and am făcut prima gastroscopie cu Bogdan. So thank you very much, and I will start a hot topic for which there are no guidelines. There is no paper to say you how to handle submucosal tumors based on its location, size, and mainly we are focused on our personal experience. So let's show you some my concerns, my experiences on this topic. So when you have a submucosal tumor, you may wonder how often are you going to do the follow-up. Most guidelines say about 3 years, every 3 years. Many times we have problems with definite diagnosis. So EUS, it's good for diagnosis, but it's not always possible to obtain a definite diagnosis. For example, let's suppose you have a lesion at the fundus, at the tip of the fundus. It's not easy to have a tissue acquisition with an EUS scope. Dr. Saftoiou, maybe you can. I cannot always, okay? Then you have the question, should I remove it? It's your surgeon and other gastroenterologists say, it's benign, it's small, it's less than 2 centimeters. It will not kill him. But you know that you want to remove it. And then you wonder, how I'm going to remove it? Will I do SD? I'm going to do STER, I'm going to use Ovesco. There are many questions. And you will always have someone to tell you why to remove it. And the surgeon will always want to remove it. Okay, so there are many, many questions. What are the types of submucosal tumors? This is the list of most of them. And the yellow ones are the most common and the ones that I have encountered too in my practice. So let's ask you, can you imagine what is the final diagnosis in all these 6 scenarios? Dr. Deculescu, what is the lesion in the fundus?
Rather hard to say because I don't have all the vision of this.
Okay, it's a 40-year-old man with no symptoms. And he has this lesion about 1 centimeter in the fundus.
In the fundus.
Okay.
Yes, maybe it's.
There is a central depression. It's very red and it bleeds easily.
Maybe can be also a pancreatic ectopic pancreas.
I will give you one more clue. There are many more lesions like this at the fundus, but more smaller in size.
Oh, so there are a lot of them.
Some smaller than this. Okay, I will not press you because I know the answer. Let's go to the second lesion, or even the third lesion. I suppose you cannot tell the definite diagnosis.
Well, right now it's rather difficult to say.
It's impossible. Okay, maybe for the fourth lesion at the sigmoid colon, this is a soft lesion. You press it, it moves, it has the pillow sign. This is a lipo. Okay. The fifth lesion at the antrum. This is also very characteristic. You should know the answer. So it's at the antrum, before the pylorus, it has a central depression. This is? Yes. And sixth lesion, it's impossible to know the answer, okay? So these are the responses. So the first one is a net. This patient has G1 nets, multiple nets. We are not supposed to remove them. It's not obligatory because they are always benign, almost always benign. The other lesions are rare, and only with tissue acquisition you can learn the definite diagnosis. Would you remove them? Dr. Saftoiou, would you do gastrectomy for these patients? Okay, so most of them, let's be honest, they are benign, okay? But you can remove them, okay? And that's the trend right now. We can remove them. Why we can remove them? Because we have stolen the technology, we have stolen the technique from our Japanese experts, And now you see people around the world that can do it. Let's continue. So, what do you think of diagnosis? The first lesion is a pedunculated lesion. It looks like hyperplastic lesion, but it's not. The mucosa is very clean. It's very soft. Any ideas? I didn't know the answer before I remove it, okay? So, I'll tell you the answer then, later. The second lesion. So that was a very tricky lesion. This is a hard lesion. It is located at the angulus. When you touch it, it's very hard. But this patient, unfortunately, had a esophageal stricture, and I could not do EUS. And at the CT scan, there was a hypervascular mass at the angulus. So I supposed it was a cyst. The third lesion is a very typical lesion of the esophagus. In 90% of cases, you can pose the diagnosis with just this image. The fourth lesion at the mid-esophagus is very rare. The lesion at the cardia is also very common. And this is the lesion at the rectum. Okay, have you ever seen a lesion at the rectum? Submucosal tumor at the rectum, anyone? Yes, you. Okay, let's see. First one, fibroid inflammatory polyp. This is a benign lesion. The second one was a pancreatic rest, incredible. So it was not a cyst. It was situated at the angulus. The third one is a typical lesion, Abrikosov lesion, very typical. The fourth lesion was a net, extremely rare scenario. The cyst at the cardia, and then a cyst, yes, a cyst at the rectum. Would you remove them? You can remove them, okay? It is not tricky. There are several techniques, several risks. The surgeon should be near you, but it is feasible. And that's the principle of this lecture, to show you that the trend has changed. So, what are our tools? Depending on the anatomy, depending on the location, on the size, and on our experience, we can use several methods. We can use conventional ESD if the lesion does not go very deep into the muscular layer. We can use tunneling if the lesion goes deeper, or use our surgeon to close our perforation. In addition, we can use Ovesco for small lesions, or even banding for small nets. And this is a table that I made based on my personal experience on how to implicate all these approaches depending on the type of the lesion. So if you have a poorly submucosal lesion, you can remove it with ESD. But let's suppose that the patient takes anticoagulants. There is a big interest to use STER for this lesion because you will protect the mucosa from bleeding. You will protect the vessels with a flap. But don't do STER for a net, because nets are not poorly submucosal lesions. The epithelium is also involved. Ovesco is extremely useful for duodenum, but it is also extremely difficult for the duodenum because you cannot always pass the pyloric ring, and you may need to dilate the pylorus prior to do Ovesco. And then LEX. LEX is very useful for submucosal tumors of the duodenum, especially, I think in Japan they use it more because you may have lymph nodes and the risk of delayed bleeding and perforation is extremely high, but it's also very useful for cysts when you are not able to close the defect, and let's be honest, it's difficult to close a perforation in the stomach. Now, that's another way to present the strategy. Let's suppose you have a net at the stomach. Depending on the size, you may choose to do ESD if it's more than 1 centimeter, or to banding or EMR if it's less than 1 centimeter. For other submucosal tumors, ESD or STER if the muscle layer is not involved. But if you have the muscle layer involved, then you should be very, very careful. It depends on the exact anatomy of the tumor. And you can choose between ESD, STER, LEX, the feasibility of tunneling or not, in order to choose the right method. And let's see some real cases. So here we have a submucosal tumor that is not easily visible at endoscopy, and it is located at the cardia. For these lesions, we can apply STER. We can use a tunnel starting from the esophagus, and we arrive until the cardia. One of the difficulties in STER is that we don't have traction. And with this video, I will show you a new technique using the mantis clip. So traction is key for safe and fast dissection, whatever procedure you're doing. And but when you're doing tunneling, you cannot have traction, especially for submucosal tumors. Why? Because you cannot grasp the hard tissue of the tumor with the clip. Guys, I think the video is paused. Can you go a little bit forward? Technical service? I think the video is paused. Can you, yes, advance it a little bit more? Yes, okay, now it's okay. So this is our tumor. This is a lesion located at the cardia. In direct endoscopy is not visible. So for that case, we do a small incision at the lower esophagus. I like to use underwater for the first part of the procedure for entrance into the tunnel. We do a slight rotation, and now you have the muscle layer at 7 o'clock. You have the mucosa at 2 o'clock, and now we try to enucleate the tumor. This is a knife called flash knife by Fuji. At the left side, we have the muscle layer, and now we see that the tumor is attached to the muscle layer. The principle of STER is that you can do perforation without an issue. So here we can detach the tumor from the muscle layer and even do full thickness resection without an issue, because we will later close the perforation with a flap. In STER, what is difficult is to access the distal pole of the tumor. So for that scenario, we thought that we may use the mantis clip. This is a clip which is very strong and has tooth that are very sharp at the edges. We grasp the hard tumor, okay? And then we use the thread to pull the tumor, apply traction, and extend the remaining muscular or submucosal fibers. In this way, we expose the difficult part of the tumor, difficult to access. And this is another knife, which is called IT Knife Nano. This is a ceramic tip knife, insulated tip knife, and you see at the end of the procedure how we recuperate the tumor easily by pulling the thread. So this was a STER with traction, a new concept. And this is how we can deal with challenging lesions at the cardia. And for the surgeon, it is very difficult to remove a lesion at the cardia because he has to remove a part of the esophagus, a part of the stomach. He may then have a leak, stenosis, so it's a major procedure with major comorbidities. Now, the same principle, and I'm talking about traction of a submucosal tumor, can be done even in the stomach. So this is the lesion of pancreatic rest at the angulus that I thought it was a cyst, and I had to remove it for diagnosis. It was removed with the same technique. And I'll show you one more case. This is another lesion at the fundus, but this time tunneling was not feasible due to the location of the tumor at the tip of the fundus. So tunneling eventually would be possible, but very challenging. So in this case, we did something different. We did STER in retroflexion. So STER is usually done in straight position, but we can use the same principle in retroflexion like this. So we do an horizontal incision, and since we don't have direct access to the tunnel, we use traction to keep the tunnel open. And then progressively we try to enucleate this gist. In terms of settings, I like to use endocut for avascular areas and spray coag when we have a lot of vessels. As you see here, it is very difficult to access the posterior, the distal part of the tumor, and you may provoke damage to the adjacent mucosa. The purpose here is to enucleate progressively the lesion until we reach the serosa. When we reach the serosa, we're going to do an intentional perforation. And at that point, we should be ready because the distension of the abdomen will compromise the way the patient respirates. Now we switch to another more aggressive knife, hook knife, for myotomy and intentional perforation. And what you see here is the fat, okay? So this image would be an image of complication in the past. But now we are in an era where this image is part of our life eventually. The specimen has recuperated, but we are not done yet. Now we have the most difficult part. Now we have to close this intentional perforation. And the new generation is very happy and very lucky because now we have many tools. For that case, I use the technique discovered by the Chinese, the loop and clip technique. So this technique with cheap materials is the following. We advance an open endoloop around the edges of the defect, and we use multiple 7 or 8 clips to fix the loop around the defect. And then, when we close the endoloop, we close the defect. So this is the loop and clip technique. But now, you are very lucky because you have the X-tack, you have the mantis clips, and maybe this can be done in a more easy fashion. Finally, I'll show you some other rare cases. This is an obstructive lipoma of the duodenum that was removed by doing a tunnel starting from the stomach. This is a case where tunneling was not feasible, so a lesion at the posterior part of the gastric body, intentional perforation was done, and the hole was closed with a loop and clips. At this point, I want to tell you that when you do this procedure, you should be at the surgical room, and you should be ready to puncture the abdomen because when you do the perforation, the abdomen distends, and you should do puncture with a needle and the syringe with saline in order to decompress the capnoperitoneum. And these are some other cases where you can use a pullover stitch to suture the wall. Very difficult, it takes a lot of time, and it doubles the cost of the procedure. And finally, a case of the use of ESCO. So this is a case of a net at the bulb. So ESD here is very difficult. Professor, would you do ESD for that net? Would you do ESD? Yeah. You would? ESD. All right. So I don't have the skills, so I did Ovesco. So how to do Ovesco? You have to dilate the pylorus because this device measures 2.3, I think, centimeters. And then you should use a rat tooth, grasp the tumor, and without aspiration, because it's very dangerous, you should pull the tissue in the cup and then deploy the clip and then press endocut or autocut and cut. So you do suturing and perforation at the same time. And that's probably the best way to remove a net of the duodenum. Now, you should know that nets of the duodenum give metastasis very, very fast. When the lesion is beyond 1 centimeter, the risk of lymph nodes is very high. You should always do a specific PET-CT, 68 garotate PET-CT before to remove such a lesion, because they have very often metastasis. And actually, the same patient had a pancreatic net that was treated by RFA. What is the role of EMR or of banding? It's best suited for small nets, less than 1 centimeter. And the good thing is that you are not obliged to cut them. You can just band and go. So you place the band and you don't cut. And for type 3 nets, we have more and more evidence that up to maybe 2 centimeters, we can remove them endoscopically. Finally, gastric legs is for lesions where we cannot close the defects, for GIST, for example, but it takes too long. So the cooperation with the surgeon in the surgical room can take up to 5 or 6 hours. So it's not an easy procedure. So the synopsis of what I told you is summarized in this animation. If you have a small lesion, you can do EMR or Ovesco. If you have a tumor that does not penetrate deep the muscular layer, you can do ESD. Although the term ESD is not very well used for this indication because you cut the muscle eventually. If you want a mucosal cap to avoid the perforation or the bleeding, you can do STER. And if the lesion penetrates, it's transmural, then you should always use STER. If not STER possible, the next best case is ESD, but with closure with all these techniques. And if you cannot do that, the surgeon should be ready to do legs. And if you have a poorly extraluminal lesion, then it's only legs or STER. In conclusion, the trend has changed. We live in an era where submucosal tumors can be removed, and answering to the question why to remove them is because if they are small, we can remove them. When they become bigger, we will not be able to remove them. It will be a procedure for the surgeon with all the comorbidities and the anatomic restraints of a surgical gastrectomy. In addition, we should consider the psychological burden of the patient who has to do again and again gastroscopy US for a small GIST that is growing up, and also the financial cost of such a long-term follow-up. Depending on the location and the size, we choose the appropriate technique. But when we do all these techniques, we need appropriate treatment and very good closure techniques, and a surgeon which is ready to intervene when we'll have difficulties. Thank you very much for your kind invitation and attendance.
Thank you very much, Georgios, for this very, very interesting presentation of your own experience. So I understand there are maybe 3 take-home messages for all the audience. You have to try to define as much as possible from the endoscopic vision of the lesion, and to try to not to have biopsies before. For many of the lesions, endoscopic ultrasound might be compulsory in order to define the depth of the lesion. And for most of the lesions, the real histological diagnosis is after you remove this lesion.
Exactly.
So questions, comments? Well, very, very interesting. Thank you so much.